Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
So hello, I am Isabel Olivera, a medical writer for the EHA, European Hematology Association, and welcome to this podcast on the ethical considerations surrounding CAR-T therapy. I have the pleasure to have here with me today Professor Marie José Kersten. Welcome, Professor Kersten.
Thank you.
Can you please introduce yourself?
Yes, so I'm a professor of hematology at Amsterdam University Medical Centers. And I just until very recently, I also was the chair of the EHA lymphoma group, which is a scientific working group specifically for lymphoma doctors and researchers. And I also chair the HOVON early phase group for lymphoma treatment and the HOVON immune effector cell.
CAR-T is a therapy that involves a very long procedure and costly procedure, and it has brought many problems of access to this. So my first question is, how are these patients selected to access this treatment?
Yes, so there's many different aspects to this. If you look at the European perspective, there are actually many countries where there's still completely no access to CAR T cell therapy, especially in the eastern part of Europe. And then there's a difference between access to commercially available CAR Ts and access to CAR T in the context of a clinical trial. And also there's no equity, so there's countries where there's a lot of trials, also commercial treatment. There's countries that have neither or only one, so it's very different. And for example, in the Netherlands, we have originally already participated in many clinical trials, both for lymphoma and myeloma. But we only have commercial access now for lymphoma and not yet for multiple myeloma. Because it's not reimbursed yet in the Netherlands. So it's very different from country to country and even within countries.
So let's talk about the example of the Netherlands for the moment. How do you make the decision to refer that patient to CAR-T for CAR-T therapy or not?
Yeah, so we have 7 CAR-T treatment centers, which are the academic hospitals. And all the general hospitals can refer their patients to the CAR T cell centers, and we have a centralized approach. So we have a form that can be sent to a central email address, and we have a meeting, national meeting twice a week, already for 4 years, where we discuss all the possible indications. So all the patients that are referred for CAR T cell therapy are assessed for eligibility within this national CAR-T tumor board.
And how is the decision made about who will benefit the most?
Yeah. So we look, of course, at whether it's the right indication. Does it fit the label for commercial treatment? What's the condition of the patient? Does the patient have any comorbidities? Does the patient have any other options? And then we have like a consensus decision on whether or not we think the patient is eligible. And then the patient is referred to one of these CAR-T centers, which is all within the same week. And of course, then the patient still needs to be screened to see whether or not the patient is actually fit enough to undergo the treatment, and also whether or not we have possibilities to bridge the disease while waiting for the manufacturing of the CAR-T cells.
So, who is in these tumor boards?
Yeah.
What is the composition of the people who have to make this decision?
Yeah, so all the CAR T cell centers are present, one of the hematologists from these centers. And also we have colleagues from the general hospitals who also attend. And if a colleague wants to personally discuss the patient during the tumor board, it's also possible. So we have like more than 20 people usually attending the tumor boards.
What are your principles for prioritizing which will get the treatment and who will not?
Yeah, that's a very good question, and it's one of the most difficult to answer because there's like a list of things like we look at the WHO performance status. Does the patient want this treatment, right? Because it's an intensive treatment journey. Are there any comorbidities like cardiac or renal function abnormalities which would impede safe treatment with CAR T cells? So there's many factors that are important, but then still, it's if you ask me to prioritize, it's quite difficult because, for example, we have clinical trials also for patients to be treated with CAR Ts for non-registered indications. But if it's a phase 1 study, we most of the time have limited slots for the trial, and then it's really hard. Is it like first come, first serve, or would you go for the most fit younger patient instead of the older, frail patient? Those are ethical issues that are quite impossible actually to use. So we look at of course we look at the patient, and if we think the patient cannot benefit from this treatment, it's a very difficult decision. But then if the patient is just too ill and the disease is progressing so fast that we cannot bridge the time between the apheresis and the infusion, then we sometimes have to make the decision that it's not feasible to do the CAR T cell therapy. And it's heartbreaking because this might be the last straw for a patient. But we don't want a patient to undergo this whole procedure if there's no hope that the treatment will benefit the patient. And we're pretty sure they will have side effects, which will make the last weeks of this patient even harder.
So there is a procedure for the approved treatments. There is a national procedure, very well, let's say, described and very, the decision.
But still, we have sometimes very tough discussions also within the tumor board, because you can have like sort of this is the population, but still no patient is the same. So sometimes it's a little bit outside the normal treatment pathway, and then we have tough discussions on whether or not we should proceed. It's not always easy.
But in the case of referral to a clinical trial, then the decision is made by the doctor that is sponsoring. Is the the
investigator?
The investigator of the clinical trial.
But still, for a clinical trial, there's even more strict in and exclusion criteria. Okay. So there it's more like it's more rigid, because there's usually no possibility for waivers. So the patient just has to fit, like this list of 12 inclusion criteria and 20 exclusion criteria. So it's much more, it's even more strict, I would say.
But in any case, I understood that there are sometimes too many patients that fit the inclusion criteria. And so in that case, the doctor will have to make the decision by himself. So we do it with a team. A local team.
A local team. And sometimes we even discuss also if the trial is also open at another site in the Netherlands. We also sometimes discuss, if there's a possibility for this patient to be treated earlier, then we refer to another site.
So at the end of, with all these possibilities, it's still a scarce resource.
Yes.
Are there many patients that would, in your opinion, benefit from CAR T and are still not getting access to it?
Yes, I think so. So we don't know exactly how many, because it's very difficult to find the denominator for these. We estimate how many patients would theoretically be eligible, and we also looked at those data in the Netherlands Cancer Registry. So we still think some patients might not be referred. Especially there's still some hesitation to refer older patients over the age of 70, where we have seen actually also quite good results from CAR T cell therapy, at least for lymphoma. but there might be some hesitancy because of age or because of it's an expensive treatment. And should you give it to an 75-year-old? Should you give it to an 80-year-old? We can see there's still also some hesitation around those issues, which are also important. But I do think there's still patients that are not referred. And also, patients might not be referred in time. So I think we're doing much better already than maybe 3 years ago. But sometimes the patient already started a treatment which might not be beneficial for the CAR T cells, where we would have preferred to have the patient referred earlier. Yeah.
So you touched in the fact that this is a very costly procedure.
Yes.
And in general, in Europe, the health services fund these treatments, all the treatments. So how does the cost come into consideration?
No, so the problem or the issue in the Netherlands is more that some of these expensive treatments are not reimbursed at all yet. Okay. So there's after the treatment has been approved by EMA, there's market authorization, there's the HCA, the Health Technology Assessment, and then it is decided whether or not this is reimbursed in the regular care of the insurance. And there's price negotiations between the Ministry of Health and the companies. So this is a lengthy process. So that means for some time we won't have access commercially to those treatments. Yeah, so okay. It's different in different countries, but in the Netherlands it takes a long time before there is reimbursement. But once there is reimbursement, all the patients who check the eligibility criteria for commercial treatment could get the treatment without any other administrative procedure, which is different than in the United States, for example, where you might have to have individual permission from the insurance company. So in the Netherlands, we are actually, at the moment, we are doing an investigator-sponsored study in commercial indication for DLBCL, where we actually, this is funded by the government, by a government grant, where we actually randomize patients who either get commercial CAR T cell therapy or point-of-care manufactured CAR T cells, which are manufactured at our own stem cell labs. And this might be a cheaper way to manufacture CAR T cells, and hopefully it's equally effective. But that we don't know yet. So that's what is being investigated in this clinical trial. Yeah.
So the treatments that are available now from academia in the Netherlands, they are at the moment just in clinical trials, not as part of the
hospital exemption.
Yes.
No, that's still in the context of a clinical trial. Yeah.
Always in
Yeah.
Okay.
Yeah.
So for some of these indications, for example, multiple myeloma, there are other possibilities, or immunotherapies now available.
Yeah.
And
bispecific antibodies, or
yes, and there are also chemotherapy, of course, and there are really many possibilities. How is the decision made of which is the best treatment?
Yeah, so also for myeloma, we also discussed those patients in our local multidisciplinary team meetings. I think the problem, or not really a problem, but in the myeloma field, what you see is that many of these newer treatments also go to first line. So now in first line, the patients get daratumumab and VRD, and then high-dose melphalan and lenalidomide maintenance. And that's only the first line. So they have many drugs already in the first line, so it becomes more difficult. Of course, they have longer remissions, but it becomes more difficult to treat the patients when the disease comes back, because they already had many of these treatments. I think bispecific antibodies and CAR T cells are really going to make a major difference. But also, if you look at the costs of the whole treatment trajectory for a myeloma patient, it's really very costly affair.
Yes, other immunotherapies are not necessarily much cheaper
No.
than CAR T.
Yeah, and you give them for a prolonged period of time. So CAR T, I'm not saying it's cheap, but it's very expensive. But you only give it once, whereas a lot of these other immune therapies, you give them until progression. Yeah.
So at some point, so at the beginning, CAR T was given as really last resource.
Yeah.
You had exhausted all possibilities,
Yeah.
and this was really life or death.
Yeah.
So from an ethical point of view, the decision was easier in the sense that if this is your last chance,
Yeah.
a patient would have signed any informed consent.
Yeah.
Now, these therapies are moving into earlier lines of treatment. So there might be a bit more of a choice between, an immunotherapy or a CAR T.
Yeah.
And are the patients brought into this decision?
Yeah, of course, you discuss with the patient, but it's not that easy because we don't have all the data yet on what the influence of sequencing is. So, for example, if you give bispecific antibodies first and then CAR T, is that as good as the other way around? We don't know yet. There's some indication that if you treat with bispecific antibodies first, you might exhaust the T cells, get loss of the tumor antigen, and the CAR T cells might not work as well. So there's still a lot of research needed to see what's the best sequence also of therapy. Yeah.
Yes, so in that case, the patient's wishes play a role, I guess, but also we are waiting for more results to make sure that
it's the best thing to do. Yeah. Yeah.
What would you like to say for a hematologist that is faced with the dilemma of having a patient that has could possibly have CAR T therapy, but it's a bit difficult to see if they will benefit or not? Always refer them?
Well, at least discuss with a CAR T center whether or not it's a good option, and also if the patient has some comorbidities or is older, there's also the possibility to do like a geriatric assessment to see whether or not the patient could, support such a treatment. But I think it's always good to discuss whether or not the patient would be fit, rather than making the decision not to refer. And I also think it's very important, more important these days, that you try to plan ahead, right? So if you think the patient in the next line of treatment might be eligible for CAR T with a lymphoma, we have learned that it's very important to avoid the use of, for example, chemotherapy with bendamustine, because it negatively affects the T cells. So you have to actually really plan ahead if CAR T or bispecific antibodies might be an option in the third line or whichever line is available. Yeah.
So how do you leave the tension of having to decide which patients will get the treatment or not? This discussion, how do you leave it as a part of this discussion?
So I think it can be extremely difficult, but it's really important that you can do this with your colleagues. So it's not you're sure that everybody has a chance to give their arguments and then make an informed decision, and that you're not alone in doing it.
Is there something else that you would like to say about this, the ethical dilemmas that you face with CAR T patients?
Yeah, well, I think we should have more attention for those dilemmas, and it's very important that you're aware of it, and also that the patients are aware of these discussions. So I think you should organize joint discussions on how to work with these dilemmas, and make also everybody understand how we deal with these dilemmas. Yeah.
Yeah, understand it's a complex situation.
Yeah.
There will be no...
There's no
never
easy
an
answer.
Easy
No.
answer,
Yeah.
exactly.
Yeah.
But the best is at least to talk about it,
Yes.
to make sure that the decision was weighed and everybody comes out of it at least feeling that every point of view was considered.
Yeah, absolutely. Okay. Yeah.
Anything else you would like to add for the audience?
No, so there are some formats that also help, because we sometimes we did treat the patient and the patient had bad complications, and we feel bad that we gave the treatment, and sometimes we have like a session together with the nurses following such a case to discuss what happened. Should we have done this? What could we have done different or better? And that also really helps, like a moral dilemma. We also discuss sometimes after something happened, or
to review how the decision was made.
Would do the same the next time, or would we do it differently? What would have helped? That's also important, I think. Yeah.
So always be critical of the procedure.
Yeah, critical, but also mindful for what it means for everybody.
Yes.
Especially also for the nurses who take care of the patients on a daily basis.
Yes. So that everybody is taken on board. It will help the patients and all the healthcare staff.
Yeah.
So thank you really very much for this insightful discussion.
You're welcome.
Thank you. So thank you, Professor Kersten. And thank you to all the listeners.